All right. Okay, so thank you, Jason and Brent, for inviting me to talk. I'll introduce myself in case some of you guys listening online haven't met me before. So I'm Paula. I've been working with Brent and Jason almost from the beginning here at P360. My first degree after school was an exercise science degree, and then went on to do a master's of physiotherapy. And my most predominant thing I do in terms of physio is pelvic health, and particularly treating persistent pelvic pain. So I'm going to talk about the pelvic floor today and just some different things that you might come across training women and some practical tips. But I want to start at the very beginning with the anatomy and function of the pelvic floor, because even in a physio degree, we actually don't do a lot of this. This is like postgraduate education that we learn, unfortunately. And as you would all know, it's just because we don't have much research in women. It's all starting now. So just to give you a bit of an overview of the female pelvic floor, first of all, it's really important to understand that the pelvic floor muscles is skeletal muscle tissue, just like any other muscle that we're looking at the gym. So we really actually just need to train it the same way. So I want you to sort of think of it as quads, biceps. It's got the same properties. It's just that it happens to be an internal muscle. So we either feel like there's taboo talking about it, or maybe don't have language around how to bring it up, particularly if you're a male coach looking after women, for example. So if you look inside the pelvis here, obviously just to orient yourself, this is where the pelvis sits in a female pelvis. Looking inside, we've got what we call our deep pelvic floor muscles and our superficial pelvic floor. Both are important for different reasons. So if we look inside here, most of that big tissue in here, that orange part there, is what you'll see as the deep pelvic floor muscles. So kind of grossly speaking, they attach to the pubic bone here at the front, and they sling all the way around and attach to the tailbone at the back. So if you look from underneath, they basically sit and support underneath the pelvis, and just to imagine, our glutes would then sit over the top of that. So the glutes actually function as a secondary support to the pelvic floor, which is quite important to know. We also then have the superficial pelvic floor muscles, which are more situated around the vaginal opening in women. And then we have the external rotators of the hip, things like the obturator internus, which we actually see as a pelvic floor muscle. We kind of classify that as a pelvic floor muscle. Obviously, it's got functions as an external hip rotator as well. But it's something we look at a lot because a lot of women, particularly with pelvic pain, have really tight hip external rotators. And often we can only access that internally. So they might go to a musculoskeletal physio for a really long time, then come and see us once, and we go inside and go, oh, is that your pain? And they'll go, oh, yes. So we sort of think of the external rotators as part of the pelvic floor. And then we've also got a muscle right at the back here called the coccygeus, which technically is a pelvic floor muscle as well. So if we think about then the function of the pelvic floor, for the big levator muscle, so we generally call the deep pelvic floor the levators, which gives you a hint as to what they do. So they lift up. So they're really important. If you think of what's inside the pelvis here, we've got the bladder at the front, the uterus in the middle, and the rectum at the back. So if you, just grossly speaking, take those muscles away, the pelvic organs here are going to collapse down. So that's an important consideration when you think of women lifting heavy weights, which, as we know, particularly in the perimenopausal, menopausal phase of life, that's a big thing that we're promoting now, that we need to be lifting heavy for muscle protein synthesis and for bones. But we have to consider how much load is being put on the pelvic floor. I'll get to that a little bit later. And then, so they hold everything up in place. They've got a function in pelvic stability because there's still a muscle that's attaching to joints, so the pubic symphysis here at the back, the pelvis on the other side, so they have a role in pelvic joint support, and also a sexual function. The superficial pelvic floor muscles, so the ones that are a bit more around the urethra and the vaginal opening, are more involved in urinary continence, so they get more of a squeezing function around the urethra. So they're important in terms of like leakage with coughing, sneezing, laughing. The deep pelvic floor muscles are as well, but it's important to know that they are different. They have different functions. So Is everyone with me so far?
Yeah.
Yeah, we're all okay? Yeah, okay. I'll pass it around so you can actually have a look. So I think it's important to check out those muscles so you're familiar with them. So I was going to talk mostly about stress incontinence just because that's what Brent asked for initially, but if there's anything you want to ask or anything that's coming up with women, I'm happy to talk about that. But in terms of incontinence, there's different types of incontinence. I'll just cover it just so you have a bit of an understanding. Stress incontinence is the one that you'll come across in terms of exercise or at the gym, but there's also urge incontinence, which is where men or women can get that sudden urge out of nowhere to pee, which isn't necessarily linked to bladder fillage. We don't need to go into it, it's not something you'll really see, but just to know that there's other types, and there's mixed incontinence where it can be a bit of a mixture of different things. In terms of stress incontinence, we can get stress incontinence for many reasons. So when you're seeing it at the gym, it'll be things like they go to do a maximal lift, for example, and they might have leakage, or they might run or skip or jump and they get leakage. It might be as soon as they go to do it, or it might be after 30 seconds to a minute they start to get leakage. So they're important little things to kind of think about when people are talking about having leakage, because it gives us a clue as to the mechanism of the incontinence. So, for example, if you've got someone who is deadlifting, they're in the warm-up, they're totally fine, but it might be a day where we're going quite heavy and all of a sudden they do a max lift and they get a little bit of leakage. That's obviously to do with the pressure, the downward pressure. It might be that they are unable to brace properly. It might be that they're doing a bear down technique instead of a Valsalva, which is something we can talk about as well. Interestingly, I notice in the research they tend to use those terms interchangeably, and it's not accurate at all. They talk about bearing down when they should be talking about Valsalving, and then vice versa. And I find, particularly as a physio that treats women's pelvic floors internally, a lot of women do not know how to bear down, or if I'm trying to get them to do a Valsalva, they will be bearing down. So that's important to know as coaches, because if you're out on the floor trying to teach them how to do that, there's quite a big chance that they don't know.
What is the difference between those?
So when you're bearing down, you're actually pushing down. So the idea is to get downward pressure. You really should only do that when you're pushing a baby out, really. And a Valsalva is that closing down of the glottis and generating tension in the lumbopelvic fascia to get rigidity in the system.
Okay.
So when we're doing that, and you have to do that, as you guys know, if you're lifting sort of 80% or heavier, you need to Valsalva to lift, to get stiffness in the spine. That's where it can be a problem though for some women. So if you're finding women are getting leakage under a heavy load, and it's only when they get to sort of, really heavy, kind of approaching their maximum, a few techniques you can do, because it's different someone leaking under a heavy, like one lift load, as opposed to someone that's trying to skip and lift. And actually, let me go back before I talk about that. The way the pelvic floor muscles work when they're working optimally is, I often describe it like, if you think of your bicep. So a bicep needs to be able to completely relax to get elbow extension, and it needs to be able to completely flex. Pelvic floor is the same. So it should be able to completely relax down, and it should be able to completely squeeze up. For many women, that's not the case, and there's a lot of different reasons why, which I won't go into. But the way our pelvic floor should work is, for all of us sitting here now, and men have a pelvic floor as well, just make sure everyone knows that. When we're sitting here and there's no load on the pelvic floor, it should be pretty relaxed. So if you think of it like the levels of a lift going up from sort of the ground floor to the 10th floor, it should be down at maybe around 1 or 2. So there's a little bit of activity there, but not much, because there's no load there. But if I was to get up and start sprinting, it will shoot right up. Or if I was to have a really big cough, it will come up and then come back down. So in terms of movement, if we look at pelvic floor under like a functional MRI, for example, and we were going for a walk. So if I was to stand up and go for a walk, my pelvic floor would come up and there'd be this little phasic contraction of the pelvic floor. If I was to increase the speed, it would come up a little bit higher and it'd be this phasic kind of contraction. If I was at full sprint, it would be up pretty high, contracting. And then if I slow down, it comes back down. So that's important to know in terms of if we've got people out running, for example, and they say, I can't run because of my pelvic floor. I never like to tell people, well, okay, that's it, we won't do that. We'll give you something totally different. I don't think that's the answer. I think the answer is to always try to modify things in those situations. So we want women, particularly women, I'm just talking about women in terms of their strength mass, their bone density, power development, things like that. We want to try to get them doing these things rather than going, oh, okay, you can't do that, which is an easy option when you've got a lot of people, but if you can try to find ways for them to do it, what we can do is maybe get them starting with a shorter run if there's someone that maybe starts leaking after a few minutes. So there's going to be people that might leak instantly and people that might leak after running for 2 minutes, 3 minutes, 4 minutes. And the goal is always to get them to the threshold where they can do the activity without having symptoms. So that's a bit of trial and error. So it might be that we use things like, let's get you going for a little bit of a run, but I want you to slow down a little bit and shorten your stride length. And that might be enough to get them doing the activity without actually getting to the point where they've got symptoms. So the same thing applies to things like skipping, for example. So there'll be women that will straight up say, oh, I'm not skipping. And if you question why, it might be their pelvic floor. So instead of just avoiding it altogether, we can find strategies to try and get them to be able to skip without leaking. And it might be simple things. Well, one particularly for skipping, I find it's a skill that a lot of women just can't do, or men, it's not just women. They just don't have the skill. They've never really been taught how to skip properly. And it's also the type of skipping they're doing. So for example, what I might get women to do to start with is instead of thinking like a vertical skip, so if you think of the pelvic floor here, and if we're putting a force vertically directly down as opposed to just slightly to the side, we could get them doing a skipping action where we get them to find a line and all they're doing is just doing a little step like that. They can pretend they're holding a rope to get that coordination going, but that might be all they do. And then eventually they go a little bit faster because we know as you increase the speed of any movement, the pelvic floor has to respond more. What you then might do, put a rope in their hand, so we're increasing the skill. So that's a little bit more demand in the system. Once they can do that, then maybe we'll get them going a little bit faster. So just each week we're doing a little bit more. So building their confidence, we're taking them a little bit further into the activity without them getting leakage. Good also to note how long they can do that for before they have symptoms. So that's another way we can look at progressing them. So maybe the first week they can do that for 30 seconds and then they start to get leakage. We go, okay, that's cool. Next week we'll do the same. Week after that, we might just increase by about 10% and just keep building up. And that's really empowering for women to feel that too, that all of a sudden they're like, oh, okay, cool. I can do that now. Then we might move from a side to side skipping technique to maybe 2 feet together skipping. So we've got that direct vertical force coming down and just see how they go with that and then increase from there. There's also factors like what is their ground reaction force like? So are they really, you see some people and they're just pounding into the ground. So try to get them to have a softer landing. Different if we're trying to stimulate bone density though. That's another story. So the intention of the exercise is really important as well. So are you skipping for kind of power and cardiovascular benefits, or are we skipping to try and increase bone density? Because if we're skipping more for bone density, we want to get that impact through the bones. Does that make sense? So that might be something we have to look at going, okay, I want to get the stimulation through the bone, but I can't do vertical skipping or I can't get that pounding into the ground. So what you could do in that situation is maybe get them in a different position. So they're like here, and then we're pounding their feet down into the ground that way. So we're still getting the force, but we're changing their position so they're not getting that vertical downward pressure. Does that kind of make sense there? Yeah. So there's different ways that you can look at modifying things depending on what the intention of the activity is, I guess. that all right? Yep. And you can see how that's then different to someone that might be leaking under a heavy load, which was what I was getting at before, and we didn't get back to that. So when we're approaching failure in terms of the weight we're lifting, like I said, you need to be able to do a Valsalva. So that's the first thing. We need to teach people in general how to Valsalva properly and make sure that they're not bearing down. So a cue that you can use is for women, you could even just blanketly say it to the whole group. When you're lifting under a max load, you shouldn't feel any downward pressure on your pelvic floor. And I was just saying to the boys before, if you're confident as a male coach to say that, then usually women feel fine. If you say it and you're like, ooh, I don't want to say pelvic floor, I don't want to say leakage, that's when people won't disclose what's going on. So it's really important to get comfortable with your language. So it might just be coming up with a few things that you just routinely say, so that women then feel comfortable going, actually, I do get a bit of leakage when I'm doing that lift. Because then we can go, okay, cool. There's a few different things we can try. And the other thing is, don't be afraid to not know either. Like, you guys don't get taught any of this, so it's totally fine to not know, but we don't want them to be doing it and we don't know what's going on. So it would be better off going, okay, that's cool. Let me check in with me, or let me refer you to a physio or someone that we can speak to see if we can come up with some strategies. And then ideally, you can learn as you're going along with them. But the first things I would normally do are, one, it depends on the experience of the person lifting the weight. So as you will know, it takes a lot of experience to learn how to lift a heavy weight. And a lot of people coming into the gym have never really done it before, and all of a sudden we're building them up, and it might be the first time they've ever tried to lift a weight that heavy. So they don't know anything about how to breathe, how to control pressures, how to Valsalva. It might even be that their actual lift technique is not great. So sometimes it can even help to just slightly change the technique of their lifting and just go, hey, did that make a difference? No, it didn't. Okay, let's have a look at how you're breathing. We might take a little bit of the weight off and actually go back to breathing as we're lifting. And I might actually go into that in a second, but what I would usually do with people who are having leakage with lifting a heavy weight is to teach them to exhale and brace their pelvic floor under load. If no one's having problems, I never teach them that, because our body should naturally do it. So I never want to mess with someone's natural mechanics unless I feel like I need to. So we might actually go through that now, because I think that's an important thing. It's an important thing because for women, a lot of women will have had babies at some point, and there's a lot of women that have had babies and never seen a physio, so they don't know anything about breathing mechanics and how that pelvic floor is affected by breathing mechanics. But then there's also people who have just generally had back pain or pelvic pain, and that throws off all of their core, their breathing mechanics. And again, they may have never been taught how to do this. Most people that come in will have been under stress probably from the day. That throws off breathing mechanics. So it's one of the most important things, probably the most common thing I do actually. It's the easiest thing to teach, but of all the things I know as a clinician, it's probably the most common thing that I teach people, just generally how to get the mechanics of their core canister working. So when we talk about the core, does anyone know what muscles are involved in your deep core?
Transverse abdominis.
Yeah. Yeah. I'll just tell you. So we've got the pelvic floor from underneath, the transverse abdominis that wraps around here, so it tensions the lumbopelvic fascia. We've got our diaphragm up the top, it's part of our deep core. And up the spine, we've got our lumbar multifidus. So all of those muscles need to be functioning synergistically together for this to be working properly. So what we want to do, and I often do this particularly for new people, is in the warm-up, I will teach them how to, just going to hold this here. What should happen is we've got our diaphragm here sitting under the ribs. As we take a breath in, the diaphragm should come down. If you imagine the diaphragm is coming down, it's got to push the pelvic organ somewhere. So the belly should go out. If you watch a baby breathe, their belly comes out, and the pelvic floor actually lengthens and comes down. Then as we breathe out, the diaphragm comes up so the pelvic floor can come up and the tummy comes in. So it's like this piston mechanism, this up-down breathing of a piston. That's how we should breathe when we are relaxed. Like I've said, there's many reasons why people don't breathe like that, particularly for females. It's the diet culture and the sucking in culture. So you'll see women doing that all the time. They are sucking in all the time. That increases intra-abdominal pressure, which puts pressure on their lumbar discs and it puts pressure down on their pelvic floor. So oftentimes even just that sucking in is what's going to cause leakage. And if we can let that go and release the pressure in the system, that can decrease leakage. So if we are then under a sub-maximal load, so 50 to 75 sort of percent, we can breathe pretty well. You all know that if you're lifting a weight, it's getting heavy, but it's not too heavy. Usually we can breathe through that. And we want to be encouraging people to breathe. We don't want them to be really stiff under that load. It's putting too much strain through everything. So what I will teach women if they're having any issues with prolapse or with leakage is to take a breath in, so we get the pelvic floor coming down, the belly's coming out. As we breathe out, we're going to do a big squeeze up, and then they're going to push or lift or whatever it is under the load. So what that does is it gets the pelvic floor bracing up for support, and it's decreasing intra-abdominal pressure. It's different when you're under a heavy load because we need stiffness in the system. So that's the kind of transition point where we have to go, are they ready to go to that point? And if they are, then we can just work on that by looking at the technique of their lift. We can very slowly progress the weight that they're lifting and just see what happens. Maybe they can do it twice, but they can't do it 3 times. We just need to look at that. Or maybe for some people, and I've had that, I won't say who it is here because I haven't been given the authority to say it, but one of the members here I was looking after for a while, and she's got the strongest pelvic floor under the sun, but got to the point where her tissue just could not take any further load. So that's going to happen as well. It's like anyone at, if we get to an elite level, we just can't push past that barrier. Some people will have tissue that just cannot tolerate any extra load. So it might be that we get them to that point and go, well, this is going to be it. But there's 1,000 other exercises we can train to. On that topic though, there are other strategies. So for example, particularly with the postnatal population, so we know that women that have just had a baby, particularly if they've delivered vaginally, they get stretched through. What you can't see here is the fascia. So there's endopelvic fascia all through here. Fascia gets put on a big stretch if you deliver vaginally. And then you can get inhibition of some of these pelvic floor muscles transiently because of the stretch that you get on the nerve tissue during childbirth. So those first few months coming back after having a baby, we have to be a little bit cautious of the loads that we're putting down here. And we wouldn't take anyone to a max load in that situation, obviously, until we've got everything working properly.
Is that time frame individualistic as to how much change can happen?
Yeah, it is.
Recommendation.
Yeah, 12 weeks.
Yeah.
So there's a really good framework out called the Return to Running Guidelines, which you would be good actually to pop that in your resources, Return to Running Guidelines. And it goes through a whole lot of different musculoskeletal tests, but also pelvic floor tests that women should be able to achieve before they do dynamic movements. So that includes, it's running, but it also includes like Olympic lifting, box jumping, those sorts of things. So it's written really well. It's written for the general population. Or for coaches. I often send this to a lot of coaches that are going to be looking after patients of mine, just so they've got a bit of an understanding, and particularly of the musculoskeletal stuff, like the checklist stuff that they can go through and tick off. And it's things like single leg balance, single leg, bridging, single leg squatting, that sort of stuff. So that's really important. But we want to make sure their breathing mechanics are really good. We want to make sure that they can brace, pelvic floor and TA. And that they're not getting leakage or heavy sensations when they're either lifting or jumping. So a heaviness is usually a sign of pelvic floor weakness, or it could be a sign of prolapse, where you're getting that dropping down sensation of any of your pelvic organs, which men can get as well. As you would know, like men can prolapse from Olympic lifting and things like that. The strategy we can use as a physio if women really want to get into training is we can give them internal vaginal pessaries, which I've actually brought. And I've done this for a few women here, actually. And there's different types, but these are some, I'll pass these around. These are some examples of pessaries. So what we do is basically, for this one, for example, this is called a ring pessary. So we just fold it in half, gets inserted vaginally, and it sits over the levator plate. So internally, it would sit there. So even if someone is lifting a heavy load and they're bearing down, that's going to be blocked on the levator plate so nothing can come out. Okay?
Does it stay in there permanently or does it come in and out?
No, you can pull it in and out. Yeah.
Well, where does the liquid go?
Where does the what go?
Where does the liquid go?
Should they just, there'd be nothing pushing down. So
There'd
maybe,
be nothing. So,
You can pee, remember? So
but you can't pee through that, can you?
you don't pee through your vagina.
No. Right.
Okay, let's go back to the basics.
Well, this is prevent leakage, right?
yes.
No, well, no, this is prolapse prevention.
But not necessarily leakage.
No, but that's another strategy you can use, but for a different mechanism. So, good question. Good question, Jason. That's what you meant. That's what you meant. There you go. That's what you meant. He knows about the 3 holes. That bit's for socials. That comes in and out every night. Okay. You can, though, get, these are called space occupying pessaries. They can stay in. So that gets plugged up. The reason we have things like that is because sometimes during childbirth, particularly, this is good to know as a trainer when we do screening forms, if anyone's given birth and had a forceps delivery, so forceps, if you haven't heard of them, are literally like salad servers. They go in vaginally to help pull a baby's head out if a baby's getting stuck. What can happen is that the little tip of puborectalis here, which attaches onto the pubic bone, can get nicked off and you can get an avulsion. So you'll have,
Return back onto that?
it depends where the tear is.
Oh.
Yeah. So if it's come off the bone, no, it won't. So what happens then, if you imagine the pelvic floor sitting up here, nice and close, we've got a bit that's nicked off the edge and there's a bigger opening here. So anytime we're vertical beings, unlike our animal friends, anytime we're vertical there, there's a much bigger opening for our organs to come down. So we're more likely to have leakage, we're more likely to have prolapse. So I would never let anyone, and we've had some of them come through here, you guys just wouldn't know. I wouldn't let any of them lift without a pessary in. The challenging part is, because these sit on, we call the pelvic floor the levators, the levator plate, that sits on the levator plate. If that has been compromised, that will just come out. Yeah. So we might get them down into a squat and they'll feel it drop. Won't come out, but they'll feel it drop down, so it doesn't do anything. So that's why we then need things like these, because they're space occupying. They literally sit up and they suction to the walls. Yeah. So there are options, and that's important to know too. Obviously, you don't need to know this detail, but you do need to know to be able to go, do you know what? There are options. There's pessaries. Why don't we get you in to go and see a physio, and then, you know, come back in. And physios like to know that you guys know this, because then we feel comfortable sending you. Yeah, because we have confidence that you know and know how to ask them if they're having any issues with anything. And again, it's just feeling comfortable to go, you know, did that pessary feel like it was supporting today? That's all you need to ask. You don't need to go any further than that. It's just a yes, no question. No, okay, well, do we want to back the load off a bit, or do you need to go back and check the physio again and maybe get, because these come in different sizes, you can get different sizes. Okay, that's what that is. To answer your question, so another reason you can get, there's different reasons you get stress incontinence. This is important as well. So going back to stress incontinence being the leakage with coughing, sneezing, laughing, jumping, there's a mechanism called intrinsic sphincter deficiency. You don't need to know that detail, but basically it just means the little intrinsic muscles around the urethra, men and women both have this, they squeeze around the urethra, like around the lumen, like closing off on a hose to prevent leakage. So for some women, it's because those muscles are either not working, they're not strong enough. But the other thing is they decrease with age. So if we think we're trying to attract, the longevity crowd, people over 40, they're more likely to have this. For women, as estrogen decreases, we get a decrease in estrogen is something that vascularizes tissue. So if we have decreased estrogen, there's less kind of plumpness around the area. Does that kind of make sense? It's kind of thinner. So if you think you've got a urethra with lots of like bulky muscles around it, there's more support, right? But if it's kind of thinner, flimsier, you're going to get more leakage. So that's good to know because we can give them vaginal, you can't, we can give them vaginal estrogen. That's something that can be helpful. But the other version of stress incontinence is from hypermobility. So what happens with hypermobility is under load, coughing, sneezing, laughing, jumping, things like that, the bladder moves. So if you think of the bladder up in here and then the urethra that comes down. When we get any intra-abdominal pressure that's pushing down, we get a swing of the bladder. So it swings like that. That varies depending on a lot of different things, but one of them is connective tissue distensibility. What we can do is, the mechanism that stops that leakage is the pelvic floor here. If you think of the urethra coming down here, as we squeeze the pelvic floor, it pushes the bladder neck into the pubic bone. So we get this pushing in here, and it's like closing off a hose. So it pushes in. But if you get a urethra that really swings, the whole lot moves, and we don't get the blocking off. So we can actually put a pessary up so it sits on the bladder neck and gives it like a backstop. So that can help stop leakage, as well as doing pelvic floor exercises. So, obviously you guys can't work out which is which, but I think it's important to know there's different mechanisms, because if they've gone, oh, I've done pelvic floor, it didn't do anything, you can go, well, have you tried this? Have you tried that? There's other options. Have you thought about vaginal estrogen? Have you thought about pessaries? There's different things you can do, because most people will just say, oh, I've done pelvic floor exercises. But the other interesting thing in terms of pelvic floor exercises that we've really discovered more recently is that a lot of stress urinary incontinence is actually intrinsic sphincter deficiency rather than hypermobility. And the muscles that control that are different. So if they've been doing pelvic floor exercises that help with hypermobility, it's not going to fix the problem. So I'm going to give you something you can try now. Both men and women can do this, is how to contract your pelvic floor in 2 different ways. So I'm going to get you to sit man spread. Relax in a man spread position.
Do we need to be elevated? Or we can
No,
be on the floor?
you can do it anywhere. Just let your belly completely relax. And I want you to think about we've got to be mature now, you can't laugh at my cues, but you've got to think about trying to squeeze around the anus. So like you're trying to stop a fart, do a big squeeze up and then let it go. For men, clearly Rach and I don't have this lived experience, it's like lifting up your balls. So try and do a squeeze and a lift up and a drop back down. Just see what that feels like and see if you can feel a lift up, because remember I talked before about how your pelvic floor should be able to come up and come all the way down. Can you feel that you can get a lift all the way up and it can come all the way down? This will give you incentive to practice this. This is related to how strong an erection you can get, which decreases with age as well, because men's pelvic floors also decrease with age. So we're actually finding men that continue strength training have stronger erections. It's very interesting. So see if you can feel that big squeeze up and a drop back down. So that's the levators, that's those big muscles. Now I want you to think about, let everything relax again. Think about just, you're doing a pee and you're trying to stop midstream.
Impossible.
Can you feel that? It should feel different. It should feel it's more towards more towards the front, whereas the other pelvic floor, it's like a bigger movement. It's like a big lift up and a big lower down. Yeah. So I would argue that that is within the scope of what you guys do. It is a skeletal muscle, like any other muscle in the body. You should be able to cue how to get those muscles working functionally. Yeah. Obviously, it's not the number one thing you have to teach, but if you've got someone that's either male or female, if they're having any issues with their pelvic floor, the first thing I really want to know is, that's interesting, is it able to move through its full range of movement? Like any other muscle. If we were treating anything, can that muscle move through its full range? No, why not? You don't need to know why not, but you need to know, can it? Like, can you feel, you need to ask them if they can feel that. Can you feel that it's coming all the way up? Can you feel that it's coming down? And then there's little things that you pick up over time that I try to teach a lot of particularly female trainers, like things like if you're looking at a birth history and someone's had a traumatic birth, they've had tearing, they've had forceps deliveries, things like that. It's just that cue to go, that's interesting, maybe we should just check breathing dynamics. Can you feel your pelvic floor moving up and down? And then I'm going to keep an eye on them as they approach maximum load. I'm going to keep an eye on them as they're doing anything dynamic. It's pretty much all you need to do in respect to that. If you've got someone that is, around my age, I'm 47 this year, they've been coming for ages, they've never had any problems, and all of a sudden they're getting leakage. It's interesting. That's probably hormonal. It's the only thing that's changed, right? Really? So we need to be looking at that. Okay, well, that's interesting. Like, are you on any menopause hormone support? You don't have to go any further than that, but it's just giving them the, okay, maybe that's something I can go and speak to someone about, because that might help. Yeah. In terms of then breathing dynamics, if we think of how the pelvic floor is impacted by our diaphragm, our abdominal wall, there's things that we can look at in terms of getting more mobility generally in the system. So for things like skipping, for example, I will make sure someone's got a lot of mobility through their thoracic spine. So have they got really good rotation through their thoracic spine? Most people, no. So get them, doing a bit of foam rolling, a bit of rotation, thread the needles, those sorts of things to get their thoracic mobility better, because that's going to impact that movement through the system as you're jumping. I would also look at their calf muscles for skipping. So if they've got really jacked up tight calf muscles and they can't get that nice absorption of, ground reaction forces when they're skipping, sometimes it's enough just to get them, before you come to training today, just get on one of those foam rollers and can you roll out your calves, because we're going to be doing some skipping today. Or maybe even those little spiky balls rolling their feet out. If people are wearing shoes all the time and they don't have good mobility through all their little tarsal joints of their feet, that's important in terms of running and skipping, because they need to have that little bit of movement through their joints to be able to absorb forces. So there's heaps of little things that you guys can be doing in terms of that sort of thing. And even looking at technique for skipping, like, you should look pretty relaxed when you're skipping, but are people really tense? And that's often a cue for me to go, why are you not enjoying this skipping? Like, what's going on there? Is there pelvic floor issues? Are you worried about something? Like, have you got pain somewhere? They're little things to just pick up on, which might give you an opening to just throw out, does that feel funny with your pelvic floor? Like, are you feeling heaviness, you're feeling leakage, or are you just worried about it? Yeah. Any questions?
When would be a good time to refer out? So say someone's skipping or they're lifting and you notice something or they mention something. When's a good time to refer out?
Well, it depends how confident you feel in just trying a few things. Because to be honest, it's helpful as a physio if they've been at the gym and gone, actually, well, I've tried this, I've tried that. Okay, that's interesting, that's cool, that hasn't worked. It gives me more clues as to what more I can do. But if you've tried a few different things, again, particularly things like, you guys are better than me at technique on lifts and things like that. If you really worked on that and there's no change and you feel like, there's not much else I can do, that would be a good time to refer out. Yeah. But also the other thing I always ask people is, how bothersome are your symptoms? If someone's a really heavy lifter and the only time they leak is when they do 1-2 RMs once a month, maybe that doesn't bother them. Look at competing CrossFit athletes. They might leak just occasionally in competition. If it doesn't bother them.
Outside of the breathing mechanics
Mhm.
Are there any other recommendations of exercises that you would then progress people to, like ISO holds and stuff like that?
From what?
For like, say, some people that I've trained that get like sharp shooting pelvic pain, like right from the pubic, like up. Is that something that you would just go regress all the way back